Okay, it's an honor for me to introduce Professor Jarad Martin from Australia. He has a special interest in treating benign disease with radiotherapy. So.
Yeah, that's me. So thanks for the opportunity, and it's fantastic as a radiation oncologist to have the opportunity to interact with such a diverse group of people, all with the interest in the same disease. And I guess we've just got to keep on reminding ourselves it's only together that we can get better outcomes. And really, it shouldn't need to be said, but it is the disease that's the enemy. We are the friends that are going to be able to work together to be able to hopefully achieve better outcomes moving forward. I guess, as you probably imagine, not only have I come a long way to be here, but I'm actually not really a Dupuytren's kind of specialist. I'm obviously an oncologist. 90% of my work is treating genitourinary and gastrointestinal cancers, and it's only really been as a sort of something that started off as a side hustle about a decade ago, actually instigated by one of Heinrich's lectures at a radiotherapy conference, that I've sort of grew an interest in this field. Just showing my disclosures. The main one being, it's actually in my private practice in Genesis Care that's actually bankrolled my study and all my research and all my work and my attendance at this conference. But about 80% of my work is academic and in a public sort of setting. And then probably my more relevant disclosure is that I'm also a patient. This is the picture of my little pinky finger on my right hand. Now 16 years out from my limited surgical fasciectomy. So I could say I've also got a bit of a vested interest in this field as well. So I guess Hilda really went over a lot of these kind of things, but I just on one slide, just to sort of summarise something that might be clinically relevant. As many of you will be aware, back in the old days, radiotherapy used to be used for pretty much anything you could think of. You know, children with acne, ankylosing spondylitis, you name it. And the thing is, it actually kind of worked for a lot of those conditions, but the downside is that they were often treating children to high doses with a curable disease process. And so decades down the line, the sting in the tail was that there was a second malignancy risk associated with this fairly indiscriminate use of radiation. And this really, I guess, stimulated the whole field of radiation protection to try to get the balance right between risks and benefits. But looking for non-malignant disease processes, particularly ones where you've got cellular proliferation, radiation is an effective way to deal with that. And I guess some of those slides we saw yesterday from David O'Gorman and others, microscopically, Dupuytren's, the cells it's a very busy process, you know, with myofibroblasts and other inflammatory cells going on, particularly in the hot sort of stage. So for us, this is a very appealing target because proliferating localized cells we can kind of deal with. Obviously, radiation's non-invasive, which has some appeal compared to other procedures we've talked about over the last day or so. And the doses we're talking about, much higher than for diagnostic imaging, which Hilda was going over before, but much lower than for cancer, because obviously we're not dealing with malignant mutated cells with deranged function. These are normal cells. For the inflammatory processes that we treat, like plantar fasciitis, for instance, the doses of radiation are often about 1/30th of what we'd give to eradicate a cancer. The doses for fibromatoses, it's probably between 1/2 and 1/3 of what we would standardly use for a malignancy. And the real key thing is patient selection. So if we were to be treating young people with Dupuytren's, the risk would be higher. So treating older people, the risks do get lower, as Hilda touched on before. But also peripheral location, as you all remember from those kind of weighting factors, being the skin rather than the abdomen, the risks are lower. And as I say, the doses are much lower as well. So that's where we're trying to mitigate the risk of second malignancies as much as we can. I guess it's worth saying that this is part of our consent process to always highlight there is a second malignancy risk from radiation in any indication. But as far as I'm aware, there actually haven't been any reported cases after the treatment for Dupuytren's disease. It doesn't mean they haven't happened, and places like the Germans, which have been doing a lot of this through their DEGRO initiative, are actually trying to do registry-level sort of population-based kind of data collection to try to get some high-quality data to inform this. Hilda also sort of showed this, this kind of slide about how the way the radiation works is by damaging DNA in a way that exceeds the body's repair mechanisms to be able to manage that. And although this is obviously stolen from an oncology textbook, it's not just the cancer cells that die, but really any cells that we're kind of targeting that will feel the heat. So for fibromatoses, as I say, these myofibroblasts and fibroblasts can be pathological. And they do seem to be radiosensitive, as I say, doses maybe a third to a half of what we'd give to deal with the cancer. And it's not just Duputrons, but as Annika will touch on later today, the foot version Lederhouse radiation does have a role that her group's established, and then other sort of related conditions as well, such as for recurrence of keloids after it's been resected, radiation has a role as well. So probably normal people, when they go to Paris, they go to the Louvre or the Arc de Triomphe or the Eiffel Tower. I went to near the Sorbonne to get a photo of Dupuytren Street, because, you know, why not? And I guess, once again, you know, this audience is obviously an expert in this kind of disease process, but I guess two things to highlight from a radiation oncologist point of view is that I guess you don't wake up one day just with contractures. There's usually a long prodrome period, starting with the nodules and then moving forward. So this actually presents a really good window of opportunity to potentially step in early and sort of halt the process before it has a chance to get down to the end stage. But then I guess the other thing to note is that although Duputrons in a northern European population is quite common, and obviously the Dutch group have shown it to be around about the 20% sort of prevalence rate, only maybe, you know, 10% of those-ish will actually end up with a contracture. So the vast majority of people are going to have an indolent natural history. It's going to be unpredictable. Our biomarkers, you know, we're waiting for them, but we haven't got great ways of selecting who exactly is going to end up with contractures versus not. So these are all challenges for us with patient selection as well. But there is interest from patients. We've got plenty of consumers here and consumer groups represented as well. This is a group on Facebook with thousands of members, very active people looking for answers about how to manage their Dupuytren's disease. And if anybody's ever sort of had a look at this kind of group, it's really often just people looking for to be listened to and to have answers and to have access. And I think it really does illustrate, and it's a very active group, and it's not the only one. And I think it kind of illustrates that there really is patient interest in this, or consumer interest in this field. There is some data. This is Heinrich's work from his centre, looking at the controlled trial that he did, randomising between 7 fractions and 10 fractions of radiotherapy for Dupuytren's disease, and showing that the 30 Gray approach does seem to lead to a lower risk of progression than the 21 Gray approach. There was a parallel control group as well, giving a suggestion that there may be a reduction in the risk of progression with the use of radiation. But given that this wasn't randomised, it hasn't sort of maybe got as much traction in the wider hand surgical community. And this is maybe just one example of a few that are out there of when the evidence has been sort of systematically reviewed and graded and everything else, really thinking that the role of radiotherapy is still really an open question in the prevention of Dupuytren's disease being advanced, and that some randomised trials are going to be necessary. And this is one of the useful things from my point of view, coming from the oncology world, is that I do sort of bring some awareness of how to run clinical trials and do multidisciplinary work. But first off, you need to have colleagues. And so in my centre, we've now set up a Dupuytren's clinic with a couple of hand surgeons. In the middle, we've got Tanya Burgess and Brett McCallan, a couple of radiation oncologists, hand therapists. We also have clinical trial staff. And we're able to maybe just see, 15 or 20 new patients at each of these clinics, educate them about the whole Dupuytren's process, go over with them about management options, assess them, do all their measurements, and then give them sort of management options to kind of take away and implement afterwards. And then I guess once we had a platform like that, we were then well placed to set up some clinical research. And this is the randomised trial that we kicked off a few years ago now. And really, it was a bit of a kind of an umbrella trial for Dupuytren's and radiation, in that The first part was really looking at prevention of people ending up with contractures. So we had 404 hands, and these have all been accrued and randomised, finishing about 18 months ago, and randomised between standard, which is observation, and the experimental arm of the 10 fractions of radiotherapy from Heinrich's study. And then the primary endpoint is a 20-degree contracture developing over up to 9 years of follow-up. And we've got a lot of quality of life and other toxicity sort of measures we're taking as well. At the same time, we still have open an adjuvant trial because postnatal aponeurotomy, as many of you would have been aware from yesterday's talk, the risk of, although the outcomes as far as getting a flat hand are often excellent, the risk of getting recurrence over the next 5 years is probably in excess of 50%, possibly even higher, according to some reports. And so this actually may be a window of opportunity to use radiation after the procedure to try to consolidate the gains and reduce the risk of recurrence further on down the track as well. So this part of the trial is actually still open, and I'll be putting a plea out for any interested parties to help us. I'll show you a little bit of information about, I guess, the safety of radiation from this work so far, the acute toxicities and the quality of life. This is I don't think you can have a talk here at this conference without Paul Verker's name coming up at least once. So this is my nod to the great man. So thanks, Paul, for educating me about how to communicate with hand surgeons. You speak a different language. I had to write this paper in a completely different way with Paul's tutelage to get it over the line. But essentially what we had early on is originally the trial also had collagenase and surgical patients being treated post-operatively with radiation. And so we ended up with about 60 patients overall, followed up for a few years to sort of just see the safety of the radiation. And this was radiation delivered quite quickly within 4 days of the procedure. And I guess many of you might not be aware with radiation, with toxicity grading from the common toxicity criteria, but grade 1 are very mild toxicities, and you can really see the majority of people after this kind of radiation just had a small amount of sort of temporary redness or dryness of the skin. The more severe complications, any kind of wound breakdown or dehiscence counts as a severe toxicity, grade 3, and we did have a couple of those, actually one in the radiotherapy arm and one in the observation arm, and they obviously resolved with the usual sort of care afterwards. And this is, I guess, illustrated graphically here that some of these mild toxicities, they build up during radiation, but then they attenuate very quickly afterwards. Most of them are mild and very transient. And actually not that much more in the radiation cohort versus the observation cohort, because obviously they're often dealing with the surgical morbidities immediately afterwards. So some lessons learnt. Adjuvant radiation is well tolerated. We actually have now re-kicked off the study and looking at sort of consensus guidelines allowing up to 12 weeks after the procedure to start the treatment. We've embraced the Delphi definition of a 20-degree deterioration in a joint as being our main primary endpoint. Because of the very large numbers for the post-surgical fasciectomy arm, we've had to sort of shut that down. And collagenase is now no longer available outside of North America, so that's why we're now focusing on the PNA group. And we're about, a third of the way towards full accrual, and hopefully, if we can all get on board, we'll be able to get this over the line over the next 18 months or so. Just very quickly, I'll also mention just in the prevention trial, we've got some acute toxicity data from this as well. As I say, we've got over 400 hands that have been randomised. Just about all the ones on the radiotherapy arm had very mild toxicities, usually just a bit of redness or dryness or a little bit of swelling. Very rare for it to persist for very long or to be of a high sort of severity. No severe toxicities at all actually reported across all of these centres that have been involved. And the only ones that have been persistent at the 2-year mark are just a little bit of reduced sweating. So, which actually people who've had a clammy, sweaty handshake actually often thank me as a therapeutic thing for that. So, and then just on the quality of life, I'll just very quickly sort of say we collected QuickDash, URAM and visual analogue scales for pain. And really, there's been no statistically significant difference between arms, either at time points or across time either, so giving some suggestion that the radiation is not leaving any lingering major quality of life deficits. So just in my last couple of slides, I just want to sort of show some questions and answers. What we know, consumers are interested. They want us to be in this, doing work, doing some heavy lifting to get some answers, to get some data to put around these questions. There is a lot of radiotherapy available, so that, just about every major centre, certainly in Europe and Australia and North America, will have access to radiotherapy, and radiotherapy clinicians are interested. There's several of us here. We want to talk. Multidisciplinary care is something we've used in oncology. It works. We want to do it here in the benign space as well. But only through collaboration are we going to be able to get useful questions and answers moving forward. And as I say, in the short to medium term, radiotherapy is safe. And then just finally mentioning a few things about what we'd like to know. Is radiation better in the prevention setting than the adjuvant setting? Neither, both. We need to do the studies and generate the evidence and get the answers and then follow the data. We want to know what the magnitude of the impact is. Like if the radiation halves your risk of a recurrence, it's probably worthwhile. If it only reduces your relative risk by a tiny amount, maybe not. So we need to know the numbers needed to treat to be able to have an informed discussion with our patients. Do we treat the whole hand or just the involved area? We actually have got that data from Dupuytren, so we actually will get some useful information about that. Is 30 gray the right dose? Maybe, but that's another question maybe open. And then I guess as touched on previously, our biomarkers are something that we need to improve as well for patient selection. So just in summary, I think radiotherapy, it does something, but we really need to put some data around exactly what it is and what do we achieve in the management of Dupuytren's disease. Collaboration is the key. That's why I've pulled myself all the way around the world. We really want to be part of the solution, and this is the right forum for us to try to do that. And thank you for giving us the opportunity to make this pitch. And then, as I say, the better evidence is needed, but in the post-needle aponeurotomy group, we really need help. So please get in touch. Here are my details. I'm willing to answer emails, pick up the phone, travel to your centre, Zoom in, whatever. So thank you for the opportunity.
Thank you, Jarad. Other questions?
Thank you, Jarad, for this very interesting talk, and also the very nice remark on pointing out that Dupuytren's the enemy and we all are fighting it, and we better do that together. So thank you again for that clear thing. One thing I've learned about this conference is that I thought I knew anything about or something about Dupuytren, but I feel more and more like an idiot because so many people know so much more on all these aspects. I have one practical question. Since you used the word fibromatosis, which is an interesting word, and also stated that the irradiation actually stops cellular proliferation. While in cancer cells you see a lot of proliferation and so on. Now, in the times of my PhD, I looked a lot of Dupuytren tissue. I'm only a surgeon, but I also used Ki-67 staining and stuff like that. Apparently that's to point out if there is any cellular mitosis. Didn't have much staining. Didn't see many cells splitting up in two cells. And maybe David can correct me, but at the moment we don't know where the myofibroblast is actually coming from and if it's proliferating or not. There are some studies that even contradict that. So I was wondering, is it proliferation, Dupuytren? And so does it work that way, radiotherapy? Or is it cellular activation? And does radiotherapy deactivate cells as well? I also think that the post-treatment may be somewhat different because there you have the inflammation caused by the treatment, so that makes it even more different than the primary prevention idea in Dupuytren. So that's a lot of questions, but does radiotherapy deactivate cells, or does it, or is it really a proliferation Dupuytren?
Yeah, so you need cells to be cycling through the cell cycle, right? So if they're just dormant, no good. So that's why people who've just got indolent disease that hasn't done anything for the last 5 years, leave them alone. Radiation's probably not going to have much effect. Similarly, if they're in the kind of burnt out phase and it's just collagen, probably no use there either. But I think if you have got a nodule, as I guess we've seen some of the histology from just crowded with cells from some of the slides yesterday, that's probably the sweet spot where you actually have got patients who've had changes. That's why it's one of our eligibility criteria. We try to roughly say, look, if you've had change in the last 6 months, then you probably have got proliferation going on. We haven't got the ability to do serial measurements leading into the lead-in stage for the study, which would have been ideal as well. So I guess the short answer is you probably raise a whole bunch of valid questions, but we've tried to sort of mitigate that as well as we could as part of the study.
We had 20 years ago already studies from Tübingen, Rodemann, and there are also new studies coming out of Erlangen, and it's very clear mechanism. The key factor for the effect of radiotherapy is TGF-beta. The tissue growth factor is just cut down, and all the effects cascading through TGF-beta, all the cytogenes are also stopped. So at any generation...
Can you talk into the microphone, please, because I can't hear it. Thank you.
So I repeat it. TGF-beta is the key factor, and radiotherapy just stops TGF-beta activity, either early or late, any activity. So through TGF-beta activity being stopped, all the processes, the proliferation as a wound healing process, as a repair process, is stopped at any stage, even in late stage. So the more earlier you have the TGF chain coming in, the earlier is your effect. So that is the basic biological mechanism. And Rodemann in Tübingen, who had a great institute, and now Erlangen have done all these studies, and it's part of the immune cell process which is stopped in Dupuytren.
So I have a question regarding the acute effects of radiation, one of which is induction of inflammation, which my understanding was actually exacerbates Dupuytren's. And we just heard that there's a decrease in TGF-beta, which, while we think of it as a pro-fibrotic, it's also an anti-inflammatory. So that would also potentially exacerbate inflammation. So are there any data that actually addresses this sort of contradiction?
I guess it comes down to the target cells. So the inflammatory cells are, as you know, often monocytes, and they'll often apoptose at a very, very low dose of radiation. So that's why radiation is a very effective anti-inflammatory mechanism for that sort of thing. Whereas the erythema is often just increased blood flow, or the dermatocytes, skin cells getting, dying, and then repopulating afterwards. So it's kind of different cell populations reacting in different ways.
But what about the inflammation that's driven by influx of inflammatory cells after the radiation? I understand the radiation will kill the cells that are there. What about it?
Yeah. Well, I guess that's the seed and soil hypothesis, is that the radiation is also affecting the microenvironment there as well, and sort of in a way damaging the endothelium and doing other things that actually somehow retard the inflammatory process as well. And I mean, it's a long answer because, as you know, radiation and oncology, we now have immune therapy, and there's hot tumours and cold tumours, but I think the short answer, it's pretty hard to give a short answer.
One last question. Yeah.
The issue with Dupuytren is the source of morbidity of Dupuytren is from recurrent disease and the treatment of recurrent disease. If recurrence was not a problem, none of us would be here today. What I want to know is your guidance on what to tell my colleagues who have experience dealing with post-surgery. In my training, I have an unfortunate experience of dealing with, it doesn't like me, with doing repeat abdominal surgery for recurrent bowel obstruction following high-dose radiation for genitourinary, which is a nightmare at the least. What my colleagues come back and tell me is to say, well, we know that radiation results in some fibrotic changes, and dose-dependent, it may increase the chance of difficult-to-control surgical bleeding. And so I've been impressed at how soft people's hands are knowing what they often are like with Dupuytren. A recurrent question is, if a person has had radiation and the radiation has not protected them from having contracture and they need to have some kind of corrective procedure, is the risk of complications greater after having radiation? I know colleagues who will not operate on someone who has contracture after radiation. And the only answer I can give them now is, well, there's no real evidence to suggest that is a problem. Do you have any other advice of what I can tell my colleagues other than don't worry? And should this be something that we should develop a longitudinal trial of?
Yeah, well, I think you both asked and answered your question there, Charlie, in that there hasn't been great data, but anecdotally now on our trial, we have had failures in the radiotherapy arm, and our local surgeons have operated, and they're very blasé about, they find that's absolutely no different, and as you say, it's lower dose, smaller area, so we're not destroying the blood vessels, leading to that really aggressive fibrotic kind of changes that you would have experienced with the past gynae brachytherapy, where triple or quadruple the dose of radiation is given to a huge volume. But we will actually have some of that data that will kind of spill out of the DEPART trial as well. So hopefully we'll actually be able to put some numbers around that rather than just an intuition.
We have examples in body surgery where we give a radiotherapy before surgery. 50 gray for rectal cancer. It's different, but it's 50 gray. And the surgeons comment that they can better operate in these patients being pre-irradiated than getting into the body in an inflamed tissue. So pre-radiation, even with 50 gray, makes operations better possible. And in my 25, 30-year experience, our hand surgeons usually say a radiation, let's say operation after radiation, is less complicated after 2 or 3 operations before. So hand surgeons should know to do recurrent surgery. So if they can do recurrent surgery, they can do also post-radiotherapy surgery.
Yeah, so look, that's a stimulating discussion. We might just wrap it up at that. So thank